Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hey, welcome to Glenohumeral Gurus. It's my great pleasure to welcome today my friend and colleague, Dr. Sally McLaine. Sally is a therapist who works in Tasmania. Sally, firstly, welcome. It's nice to
Thank you, Margie. It's lovely to be with you and looking forward to a chat.
Can you share with us your physio journey, where you started, how you got to do your PhD on swimmers with shoulder pain, and what you're currently doing?
Yes, sure. So I started my physio journey. I studied in Melbourne, in Australia, worked there for 3 years, and then moved to Launceston temporarily for 6 months, and ended up staying here. But then was always keen to do my sports masters, so moved across to WA, Perth, and did that at Curtin, which was wonderful, really a fantastic course. Then came back to Launceston. I had already developed a really strong interest in shoulders, and in that ended up treating a lot of swimmers, a lot of young swimmers, and so developed a nice connection. Being a small place in Launceston, it's really easy to connect with clubs and coaches, and the main pool is just up the road. So I was up there quite a bit and treated a lot of swimmers, and wondered, particularly in that sort of teenage group where they're working their way up through various clubs and working their way up through squads. And noticed that wondered whether they were weak. I was using the handheld dynamometer at the time and thought, gee, these swimmers are really breaking down. They're doing a lot of Ks in the pool. So I had quite a few questions, tried to find, how do we know if they're weak and what should they be doing? And should they meet a criteria where they're a certain strength before they move up a squad? And I just had lots of questions. And so I had a couple of friends actually at UTAS who were lecturing and had their PhD, an exercise physiologist and a physio, and they were very encouraging for me to investigate this. So the thought of a PhD was too daunting. I thought, I'll do a master's. So I actually enrolled to do a master's to try and collect, with the main goal of collecting normative data. And then got convinced after that I had enough information to do a PhD, and so upgraded to a PhD. But it was too daunting to take that on at the start all at once. And then, just continued. And in the journey, I did it part-time, so I kept my clinical work going. And it was really great because I moved around to different parts of Tasmania to do the testing. And then we ran out of swimmers that met the criteria in Tasmania. I'd been to Hobart, to Burnie, and then went to Melbourne and connected with a great colleague, Helen Walker, who helped me connect with a Melbourne swim club. So we ended up testing a good number of swimmers, young swimmers from the age of 14 to 20 without shoulder pain. And that's really hard to meet that criteria because so many of them have shoulder pain. And so, on reflection, I tested current Olympians when they were in there as a junior, and past Olympians even. So we had a really good mix, but they had to swim at least 6 hours a week. But on average, it was probably, we ended up, most of them swam 10 hours a week, and our average age was about 15. So it was a really good journey. Tough, but that's how I sort of went through my PhD. And I work at PhysioTas, a private practice in Launceston. And I've been lecturing casually at UTAS, and developed their physio school has just started in the last 2 years, and developed the shoulder course content for the physio course. And I was also lecturing exercise physiologists as well before they had a physio course. So and I still work with swimmers, and I've travelled with them interstate, and I've really enjoyed working with them. They're a great group to work with.
Yeah. That's a great story, isn't it? I really enjoy listening how that has all happened for people,
Oh,
because it's kind of morphed for you, hasn't it? Driven
yes,
by this desire to help swimmers, and
yes.
it's kind of the way it has tracked. I think the most thing. So I was reading your PhD, as you do, when I prepare for that, which was
Which I can't
wonderful.
believe. Yeah.
It was a wonderful read, and I think, but even before then, knowing about your research, I think for me, the thing that was most pertinent for me was then looking at that level of strength as a predictor for shoulder pain, because one of the papers in your PhD talks about being able to predict future pain in swimmers. Can you share with us that level of the lack of strength that you found, and the predictive value, and the
Yeah.
cut point for that?
Yeah.
What do you think is
Sure.
important for clinicians to take away from that?
Yeah, there's a lot. Yeah, there's a lot to that. So that was our last study. So we had all the normative data of these swimmers, and then we followed them up over a 2-year period through a survey. Now, like any PhD journey, you learn a lot on the way. And so it's not, I wouldn't call it an overly robust study, but it was, I think I guess it's starting a conversation and leads to more questions. It really opened up so many more questions. So what we found in that, in the people that returned a survey, and we had quite a good response. I can't remember what the response rate was, but we found that young males, and so remember our average age of our population was 15, and the thing that stood out for us, because we tested flexion extension strength of the shoulder in elevation up here,
Yes.
that was because it was a functional position. So it was in 140 degrees abduction in the scapular plane, which isn't so it replicates as close as we could that hand entry catch, early pull through position, which is commonly where swimmers will report shoulder pain. So it's where strong propulsive forces are generated. So that's why we tested in that position. We didn't test right in that full flexion, because it is a bit provocative to do a maximal strength test in that position, and it did bring on some pain. So we found that males who had a strength less than 13.5% body weight were those that went on to develop and report shoulder pain in that follow-up period. So so for example, the group that had pain tested around 12%. The group that didn't have pain, that didn't develop pain, sorry, these were all tested pain-free, just to clarify. The group that didn't develop shoulder pain were up around 17%. So that gave us, when we went through the analysis with the ROC curve, 13.5% was our cutoff. And that meant, so it's only, remembering that for clinicians, it's only one small piece of the big puzzle.
Yeah.
So I think that's where it's important to acknowledge that there's so many factors that we need to consider, but it may be helpful to look at that, particularly in young males, and to get a baseline measure, and that the predictive value was it was fair. So it wasn't, excellent, but fair means that on average, 72% of the time, so males that had shoulder strength less than 13.5%, 72% of the time we could correctly predict that they would go on to develop shoulder pain. So that's not, it's some help.
It's not nothing, is
So
it?
I think that it's a helpful test. So
Yeah.
it's to go along with obviously everything else, but it's something. And interestingly enough, so many papers in the past, when I've gone through with our literature review, look at internal external rotation, but there really wasn't anything that was looking at flexion extension. And that's how we came up with those test positions, because I thought, well, if we're going to use a handheld dynamometer and test, we want to look at functional positions for swimmers. And so internal external rotation is functional in that we have strong internal rotation through in the water, but we also, in recovery position, when their elbow is high out of the water, is another position that they commonly report shoulder pain. And there's lots of different reasons that it can be for that. If they're not rotating enough, is another reason, but it's just trying to put it all together. So it's a tiny piece of the puzzle that hopefully makes a little bit of a contribution, but I still think it's worth assessing that in young swimmers, looking at that extension strength. And if they are a bit down, then there's certainly lots of exercises that they can easily do up in this position to give them that strong propulsive force. So using the lats and so many muscles and the pecs that they need to use to generate that force to pull them through the water. But then if you put that with everything else, I think it would be really nice to have a model, some sort of model where you try and get a good number with all the factors contributing to say, okay, this is good, you're strong, okay, or you're in the right position to go swimming, because it's not just about strength, and we really don't have much evidence at all. So
in terms of all those other different variables,
all the factors to consider, and of course, load management as well is one of the others.
And so just to clarify for people, your athletes are in supine at 140 degrees of abduction, and you have the handheld dynamometer on their wrist and they push forward into extension. That's in the scapular plane.
That's correct. Yep. So it's a long lever test.
Yes.
In supine, unsupported. Well, their scapula supported. And we looked at flexion and extension. So the handheld dynamometer is on the anterior part of the distal forearm, and then for flexion we put it on the posterior part
as
of
they
the
push back.
forearm as they push back, and we didn't find anything there. And rotation, internal external, was at that 90-degree position as well.
And there's nothing there either, was it?
No. So what we found, what we did, one of my goals was to set that normative database. So we've got that, which I find is really helpful as a percentage of body weight. And so we do screening for the swimmers. And one thing I think is really helpful that some of our coaches are doing now is that one of the times that swimmers are really at risk of developing shoulder pain is often when they jump up to the next level. So they might go from swimming 5 sessions a week, an hour at a time, a mix of distance and high intensity, and then they go up to the next level and they're almost sometimes doubling their volume. And that's when they do break down. And most of the coaches, they're pretty good and they're aware of it. But a lot of them now send them to us for a screening.
Okay.
To say, okay, do you think they're ready to go up to the next level, and what are the things they need to address? And it's really great too, because I think it starts to inform swimmers about looking after their bodies and doing some basic work which can help their body awareness, as well as possibly strength and flexibility, and also doing a little bit of prep work or warm-up work before they get in the pool, learning about recovery, things like that. So there's and there is lots of information that we can draw on in the research, in the swimming literature, that looks at swim screening tests and assessments. So we run them through that. So I will strength test them and see, and if they're not in that normative sort of value group or close to it, then I will get them doing a few exercises to address that. But particularly the males, I'll look at the extension strength as well, and flexibility, range of movement, looking at some trunk strength as well. And then obviously the coaches are looking at load management. So there's lots of things that we can look at. And there's some new research which is looking at the prone. So we talked about strength, but endurance is really important too. Yeah. So the prone shoulder endurance test is another test that I really value. And that, in terms of prediction of shoulder pain, two of the biggest factors that we know of at the moment, I mean, there's lots that may contribute, but the ones that we have the strongest evidence for in terms of, there's a recent systematic review and then some work by Steph Fagan, who's also a great swim researcher from Belgium. He's looked at the prone shoulder endurance test, and that's where you're lying in prone and you have your arm vertical down towards the floor at 90 degrees, and you're basically just extending that arm. So activating upper, mid traps, lower traps, supraspinatus, and looking at that as a holding a weight, 2% body weight, and bringing that up to horizontal, and looking at 1 rep per second, and looking at when there's fatigue or when they can't reach it, when they drop off, or when the scapula looks like it's not holding its position, and found that that's a great predictor of shoulder pain. And the acute to chronic workload as well, which is sort of what we were talking about in terms of loading. So if they're having an acute spike, either after a break or moving up to a different squad, then there's definitely a risk. So we're trying to sort of mitigate that as much as possible through load management, and then also just trying to help prepare their bodies a little bit more. But I think at that age, it's really great to just create that awareness for them. To learning about managing their bodies is really
it's a fantastic relationship that you've developed there that really is helping swimmers. It's really, really cool. I had a swimmer, it makes me, this isn't what I wanted to talk to you about, but I had a swimmer who came in yesterday and she was saying, she was doing really well. She has an element of posterior shoulder instability, managing well, and then she had increased her intensity of the swim and the speed. Does that fit in terms of the times that she was doing? And I previously, like you were saying, have been thinking about volume and managing volume without necessarily managing speed as well. Do you have any thoughts around that? Or
absolutely. Well, it's another element of load, isn't it? And so there's I guess the things to consider with that are fatigue, fatigue, technique, whether that is the same with the higher intensity. But the other interesting thing with some of the newer research too is that if she has had a shoulder pain, if she's swimming with a bit of shoulder pain, there's some ultrasound studies that show with high intensity swimming in comparison with endurance swimming, you get swelling of the supraspinatus tendon. And that's sort of normal, but in symptomatic swimmers, it doesn't settle for up to 24 hours.
Right.
Whereas in asymptomatic swimmers, they're showing that it settles within 1 to 2 hours, maybe up to 6 hours. But in pathological swimmers with pain, they have this supraspinatus swelling which lasts. So you're thinking that if they're doing a high intensity workout, and then like a lot of swimmers are swimming twice a day, they're training twice a day. So it's a really good rationale, I think, for pulling those swimmers back in terms of intensity, but also that frequency, allowing them some recovery time, because swimmers hate getting out of the water, and coaches hate getting them out of the water too, because they lose that connection with the water. It's really important for them to maintain that feel of the water. So we really try hard to keep them in, but it may mean then just pulling them back a little bit, using fins, things like that, reducing the intensity. And another thing to note when they're, say for your swimmer, for example, if they're getting some shoulder pain, they'll often just do kick, and they'll often use a kickboard. And that's something that they have to be a little bit careful of, because if they're using a kickboard with their arms up over their head and they've got that force, because that's a buoyant object, so they've got that force pushing them into a little bit more flexion, getting them into that sort of more compressive position around the shoulder. So that can actually be aggravating. So it's something to really watch. If you say to a swimmer, oh, you kick, don't use your arms, just use a kickboard, but they're actually better off to either have their arms by their side if they're really acute, or just even use a kickboard close to their body, or even the little flotation device, the pull buoy, just close, not right up here. So they're not going into that sort
That's really interesting. That I hadn't seen that research on the supraspinatus swelling and the thickness, but there's some interesting work happening in that space, isn't there?
Yeah, in terms of having good rationale for allowing recovery, I think it's really valuable. So it'll be interesting to see more of that. So that's coming out of Victoria in Australia. So yeah, it'll be interesting.
Yeah. Do you have, so we've sort of morphed all the way through the things I was going to talk about, which is fabulous. But do you have any other clinical tips then for swimmers? We've talked, in your research, we talked about these strength as these modifiable factors, but did you have any other, you've also talked about then, scapular strength, training load. Is there anything else that you wanted to mention that you think's relevant for clinicians who are working with swimmers?
Well, look, I did think it was really relevant when I started my PhD about one of the things I looked at was scapular position, because I thought, oh, this is, it's got to be really important for swimmers because they are so mobile. And you might have noticed with a lot of the elite swimmers, if you see on television when they've got their arms up high, or if you've seen them by the pool, their scapula just come right out. So they're almost sitting lateral to their trunk. You see these lovely sort of lateral borders and almost seeing the inferior angle. So they need a lot of upward rotation. They have a lot of upward rotation because they're so mobile, and they're getting to those extreme end of range flexion positions repeatedly. So I thought, oh, that would be really interesting to measure. And I'd seen some of the work coming out of Melbourne, Australia, with Simon Bolster and Lynn Watson measuring the scapula with the inclinometer. And I was practicing that, and I even went there and made sure I was doing the right technique and putting it on the spine of the scapula and looking at upward rotation in 0, 90 degrees and 140 degrees. So measured all these swimmers as well, and looked at reliability, and yeah, it was reliable. Looking then at normative data and comparison between swimmers. So what we found is, yeah, it's not really relevant. But no, what we did find that can be helpful for clinicians is that there is a huge variability between swimmers. Okay, so every swimmer is going to be really different, which I guess is no surprise.
No.
But what we did find is that swimmers, that you would expect the upward rotation to be symmetrical. Okay, so within a swimmer, no difference. Between swimmers, massive variability. So it means that you can look at one side, say a symptomatic side, and if it's different to the other side, then yeah, it's probably relevant, because you would expect it to be symmetrical. And that's the same actually with the strength normative data that we collected as well, which is really helpful. So unlike throwers, with swimmers, you would expect their strength to be symmetrical. You'd expect it to be equal. So it means that if you have someone with unilateral shoulder pain, you can use that other side as a comparison and a goal to reach their goals. So to reach their strength goals. So so that in itself is useful. But in terms of, I still think swimmers do need a lot of scapular upward rotation, but we know that it's quite variable.
Yeah.
So, you know, obviously if they're not upwardly rotating, they're going to have issues getting into that full elevated range. So that's important, but you would expect it to be symmetrical. So that's the
So after measuring all those swimmers, you can say they should be the same, though. That's your take home there.
Yeah,
when your patient presents for the clinician, they should expect their inclination of their upward rotation to be the same right to left. I was interested in your comment around their strength being symmetrical, because typically then I think about, you know, an effect of dominant arm, but you think if you go to your normative data, you think in swimmers they should be the same.
Yep, because it's a bilateral sport, these swimmers at this level are symmetrical, and that sort of makes sense. So I think that's really useful information.
Yes.
And remember that when we say symmetrical scapula, I think it is still important to at least to look at it in those elevated positions as well, because we want it to upwardly rotate. So so it's not, and I think all the past, you know, research with scapular dyskinesis and things like that, it's not really the best we've got is a yes, no, does it look different? But we know then with swimmers that it should upwardly rotate. We want to see that moving, but it should be, we expect it to be symmetrical as well. So, so yeah, that's just a very small element to look at. So we talked about training load. We talked about the other thing, actually, which we talked about endurance, the other thing that is helpful, I think, and that we include in our screening, is looking at range of movement as well. So we do have some evidence from one of Helen Walker's studies. We usually look at internal and external rotation at 90 degrees, because that's important for them to be able to get that nice pull through in the water. Helen Walker's study showed that you can have, in terms of external rotation, you can have it may be a contributor to shoulder pain if there's too much internal rotation, but also if there's too little. So there seems to be this suggested window of between 93 and 100 degrees of external rotation at that 90 degrees abduction that is what you'd want for in a swimmer that may be a contributing factor to developing shoulder pain if they're a bit too tight, but also if they're extra mobile.
So let me clarify, you measure them then prone, that they're active external rotation, or they're active internal?
So looking at external rotation, so you're wanting, so most swimmers will have a lot of range.
Yes.
So you're looking, so those that go right back like a thrower's
Yes.
thumb back to
Yes.
100 degrees, that will be too much if it's over that. So
Yes.
wanting them to get to their hang on, am I getting this right? Yeah, they get to their 90 degrees,
Yes.
a little bit beyond, so 90, 93, up to 100.
Right. Right.
Yeah.
And that's passive, because I typically have measured that passively in supine, but you're talking about actively in prone.
Yeah, that's how she
Okay.
did the test.
So the other thing I really wanted to talk to you about, Sally, is to tap into your experience of these handheld dynamometers, because you have measured a lot of people with your handheld dynamometers. Firstly, before I move to that, these 13.5% body weight of the, have you got is there a quick tip for clinicians, or you measure
Yeah.
their as a kg relative to their body weight kg? Is that what you measure?
Yeah. So know their body weight, their current body weight. So for
Yes.
example, and if your handheld dynamometer is set in kgs, then that's pretty easy. You'll divide their force divided by their body weight times 100. That's your percentage body weight. I've got an Excel spreadsheet. You just plug it in and it can do it easily. But obviously, if it's in newtons, which commonly they are too, you can just multiply it by 9.9 or 10 to convert it to kilos. So that can be, it's pretty easy. I think it's really important that we look at it as a percentage of body weight. And that's why we wanted to generate that normative data as a percentage of body weight. So you can then assess across the board of swimmers, all different sizes and different strengths, because obviously a big male swimmer is going to produce more force than a small female swimmer who might be younger. But that way we can look at that and use it as a more useful comparison in terms of normative data too.
Yeah, and that's really useful for clinicians to know, and just to maybe keep a running Excel spreadsheet that they can easily set that into, isn't it? So that's kind of useful. So I've also been doing some work in handheld dynamometers, as you know, and
you have
published that study together. And I mean, there's some great use for them, isn't it? And measuring isometric strength. Typically, I think that gives us just one part of that strength profile. We'd look at peak torque or peak force. Do you have any other tips for clinicians around the use of handheld dynamometers with regards, I guess, to make or break, or anything else in terms of positions if we're measuring isometrically, or using them not to measure isometrically? What are your thoughts in that space?
Yes, lots.
Yes, that's what I wanted to hear.
Okay, so for the shoulder, I always use a make test. Now I know not everybody does, but we see a lot of shoulders that are sore, and I think that the break test producing those those eccentric forces, a lot of them end up sore after testing. So I use a make test for those that are really and we've got to remember too that when we're doing a force test, that in the presence of pain, it's not really useful, because they can't generate their whole force. So I think that's really important for clinicians to remember. But that's not to say that the handheld dynamometer isn't useful at that point, because what I like to quite often do is just ask the athlete or the person to push to P1. As soon as they get pain, just stop. And so that can be a helpful reassessment tool as well. Like we might look at range to P1, but why not look at what's their force production to P1? And that can be a nice measure to see if that's changing as well. So that's one thing. Consider so if you're using a handheld dynamometer, I think it's really important to consider, okay, why are we using it? What are we looking for? Are we looking for, are they're having trouble in a particular repetitive work position, or in lifting, or in swimming? We looked at functional positions. So I think it's important to consider the position in terms of function and why you're testing in a particular range. So for example, if they've had problems getting into abduction 90, once they're getting through that range, maybe you want to have a look at that position, testing isometric abduction at 90 degrees. And also consider the position that you're testing in. So whether you're testing them, I do test a lot in sitting, but you've got to remember then that other things are going to be considered, trunk and stability and all of that. And we know through, we were chatting earlier, Margie, about our minimal clinical difference as well. And so we know that's going to be different depending on what starting position we use as well. So that's the number, the amount of change that we need to see for it to be clinically relevant. So if we say test someone who push out maybe 100 newtons, and then the next time they come in, they're pushing 105 newtons, is that irrelevant, or is that actually a margin for error? And yes, it's a margin for error because that's too small a change. So we want to see, we know, well, through the reliability work that I did with the start of the PhD, with using the handheld dynamometer, we looked at supine, prone, and sitting. And so in sitting, with all those tests we did, we for a difference to be relevant, we needed a 15% change in sitting. If we looked at, for example, if we looked at supine and looking at all those 4 tests, we needed if we collated them together, we needed a 10% change for it to be clinically relevant. In prone, looking at internal, external rotation, the body's quite supported, the arm was supported. A 6% change is clinically relevant. So that's really small. So it seems that in prone, looking at internal, external rotation, our test is a little bit more sensitive than it would be in sitting. So I think that can also help inform your use of the handheld dynamometer when you're making those decisions as to, okay, what am I going to test? What test will I use? What position will I use? There's also the comfort of the patient too, because obviously, you know, some people can't lie prone. So there's all those factors to consider. But yeah, I use the make test, and I know there's a lot of debate between the make and the break with reliability. Actually, as far as I remember from my literature review, reliability was higher with a make test. So, but if you're looking at athletes without pain testing lower limbs, I know that there's physios that much prefer the break test because they want to get a true measure of their maximal strength. And I can understand that, yeah, why they would use the break test in that situation, say for knee extension or things like that.
Can you just clarify for people who might not know make versus break? Can you explain? Just explain to people what the difference is.
So a make test is where the tester holds the handheld dynamometer against the patient's limb, asks the person to push as hard as they can, push as hard as they can for 5 seconds, and the tester needs to match the force. So they don't need to overpower the force provided by the athlete or the patient. They need to match it. So it's really important to try and hold the handheld dynamometer as still as possible. Now that might involve using your body weight, getting in really good ergonomic positions, things like that. Bracing yourself against a wall for the stronger athletes. But I find I've got really good at using my body weight, and I'm not huge, but I've been able to resist some fairly high forces. And then the break test is where you actually do have to try and overcome that force provided by the athlete, break their force, and hence the term make or break. So, so there is argument that you will get a true measurement of their maximal force with a break test.
But that involves the clinician being strong enough to
Exactly. And that's, so for me, I'm testing lots of shoulders. I find the make test works for me. And I think on the flip side, when you're testing someone who is very weak, you have to be very, very careful not to overcome their force, just to match it. And that's something that you've really got to watch too. So you've got to be very sensitive to make sure that you match the force.
Yes. Okay. That's some good advice. The other thing I'm interested in talking about is around the strength ratios. You know, we see lots published in the literature, ER versus IR strength ratio. And sometimes, I mean, I will openly confess my clinical bias because I'm worried about internal rotation isn't resultant from subscapularis, but you get overridden by pec major and lat dorsi, and that so subscap's not really represented there. I wonder what you think about my clinical bias and what you
Mm.
think about those ratios, and should we
Yep.
be using them? Should we, how is it useful? Because I think what you showed us with external rotation as a percentage of body weight sounds really valuable, doesn't it? And we know that in some other literature. But what about these
Yeah.
ER-IR ratios? What do you think?
Yeah. Okay. So yeah, interesting. Yes, I agree that as a percentage of body weight and looking at absolute values of either ER, IR, I think that's really helpful and sensitive. And I think the ratios are less sensitive, because if there's a change in one, and it will change the ratio, but you don't really know what direction. You can't pick up that sensitivity. So I don't really use them either. I use, percentage of body weight, look at the absolute values and know why I'm testing. But the other thing that I think is important, what you mentioned about, okay, IR, we're not only using subscap. I think that's another really important point, is that we are testing movements. We're not testing muscles, and that we're not able to isolate that one muscle. Sure, we've got lots of subscap activity, but yeah, it's a really important reminder that we're using a group of muscles, and not only are we using pecs and lats to generate, and subscap to generate that IR force, but we're also testing our scapular stabilizers too, because they're having to stabilize the scapula with a strong force test. So there's lots of muscles in play. And so I'm always saying to physios, remember, we're testing a movement, not only a muscle, but we can inform ourselves, because I know certainly some people with subscap tears, when I look at internal rotation, they're really weak, and it's a good thing to monitor. The only research I know, and there's probably lots more, and lots of people have looked at ratios, but I think that I understand that it's been helpful in throwers where the external rotation force drops off, and they monitor that ratio. But if it drops off more than internal rotation drops off, so if that ratio changes, then they can address that, strengthening the external rotation, and pain seems to resolve. So in throwers, I think that can be really useful. Interestingly, though, with swimmers, because of that bias of internal rotation being such a strong and important force to propel the swimmers through the water, generally, compared to the general population, internal rotation does seem to develop a stronger force. So there's a stronger bias in those ratios. But having said that, there's conflicting research. There is some research suggesting that it's really not that different to the average population. But we have seen internal rotation change and increase over a season. And we've seen that develop as swimmers get older as well. So they do need to be strong in that. But I think it's much more useful and sensitive to change to look at those absolute values much more.
Yeah, cool. Thank you. I'll carry on then. That's good. Hey, Sally, finally, we're really excited to have you here in New Zealand in a few weeks for the Sports Medicine, Sports and Exercise Physio Conference. I know you're one of our keynote speakers, so that will be really exciting. Is there anything you wanted to share for listeners about your talks, or why they should come to the conference to listen to your work on the swimmer's shoulder? I mean, some of the tidbits you've given us today have been really valuable. Do you have anything else you wanted to share, I guess?
Yeah. Well, I'm super excited to be coming to lovely New Zealand. I really love New Zealand. I think there's some similarities to Tasmania, but your mountains are so much bigger and better. Your scenery is wonderful. So I'm looking forward to that. And I'm very keen to talk about assessment of the swimmer. So some of the things that we've mentioned today, I'm keen to expand on and talk about some of the useful assessment techniques and some tips on rehab and managing the swimmer, and talking a little bit about load management and how we can help manage swimmers, not just young swimmers, but even, I mean, there's lots of master swimmers and recreational swimmers that this information can be really helpful for too. So hopefully it will aim to give you a few tips, take-home tips to manage any swimmers. And a lot of the work we talk about, I'll talk a little bit about handheld dynamometer as well, can be useful for managing any of your shoulder patients. So come along, and look forward to meeting all the lovely New Zealand physios and having lots of really good discussions. So I think it'll be great.
Yeah, cool. Well, thanks for your time again, to Sally, and thanks for sharing your expertise with us. And it's been really interesting for me to dig a little deeper into some of your research work. We don't often discuss it as we're chatting about new projects, do we? So thanks for your time. Much appreciated.
Thanks, Margie. It's been fun and lovely to chat.
Cheers.
See you.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via Telehealth Worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.